Good evening, everybody. Welcome for another week of discussion. The purpose of this discussion is mainly for fellows who have just started intervention or who are still doing their fellowship. We try to invite experts in this particular field to just give their inputs and enlighten us on this topic. So today we have welcomed Dr. Paritosh Pandey. At the outset, first I would want to thank him for taking time out his business. So again, I would want to just request all the fellows who have joined just to try to present some cases which you're not getting the audio, sir.
You.
Now, sir, I mean, I have not muted it. Can you hear me now? I'll just try to mute and unmute.
Better. No, now it is okay.
Now it's okay, right, sir?
Yeah.
So I would just again request all the fellows to try to do some activity, come up with some cases that you're interesting cases that you're doing at your institution or something for discussion, so that we can keep these discussions going, which will help all of us. Today, I have brought two cases of Moya that we did last week. So straightforward cases, but as a person who's just entering into neurointervention, or as a neurologist, there will always be a confusion of which patients to refer or which patients to refer for neurosurgeon and which patients will require surgery, and what is the perfect for the patient to undergo surgery, and what will actually be the pre-surgical evaluation. So these are the confusing points, and whenever you're doing a DSA, what to focus on, what to actually look for. So these are the points of discussion of this today's topic. So today, first I'll carry on with the case. So we had a 34-year-old male patient who had a lateral medullary infarct 7 years back. He had difficulty in speaking and he had mild weakness on the left side. He was evaluated and found to have a medullary infarct. He was on antiplatelets and he completely improved. So this guy was working in Kochi and he presented to us 1 week back with seizure, one episode of GTCS. So on complete evaluation, he had some mild unsteadiness of gait, but no gross neurological deficits. So I don't have the image, but this was his MRI report, which was done in Kuwait. It was reported as he had an occlusion of right distal ICA, supraclinoid segment, and also bilateral ICA bifurcation. And there was non-visualization of MCA and ACA1 segment. Probably they had staged it as stage 4 with some chronic infarcts and gliosis in the right frontotemporal region. So we took up this patient for DSA. So this is the right CCA shoot, where on the left image you can see that there is complete attenuation of the distal ICA with some puff of smoke appearance. And on the right side of the image, you can see on the left side, you can see the middle meningeal artery. Top, you can see a single vessel which is filling and coming onto the ACA territory. That looks like a middle meningeal artery. And second thing which we can observe is there is good cross flow and the right ACA is filling up from the left side. And also you can see the big middle meningeal artery which is almost going up and trying to fill. And you can see because always we have to look at number of superficial temporal artery in these kind of cases, just in case you are planning for surgery in these kind of patients. And there is the osseous, and you can see MCA and the middle meningeal artery filling the whole of MCA territory on the right side. So the primary objective is always look for collaterals and exactly look for which is the territory which is compensating, whether it is the anterior or whether it is the posterior or whether it's the extracranial territory which is supplying the collaterals. So this is the right CCA shoot. So you can see the puff of smoke appearance at the distal ICA terminus, and still you can see that the ACA and MCA territory is still devoid. In the next shoot, the MMA is not as large as which we saw on the left side, and still you can see a big area of hypoperfused area in the middle, which is still not being perfused in spite of the collaterals are not filling enough to fill the whole of MCA and ACA territory. So this was the right vertebral shoot, where you can see the puff of appearance at the distal PCA on the right side, and you can see the left MCA territory to an extent being filled from the left side, left PCA and the PFOM. So I'll just show you these shoots once again for a better clarity. This is the lateral view of the vertebral shoot, vertebral injection. So I'll just show the angio videos. This is the left common carotid shoot. This is the lateral view of the CCA. And this is the AP view of the left CCA injection. Yeah, so this is the shoot. Sir, if at all you want to get a better clear picture, I can just play them once again, sir. You can interrupt me anytime.
Yes. Jaishankar, can you mute your please?
I just request if at all anybody's mics are on to just mute their mics, please. Yeah. So, sir, anytime if at all you want to have a look at the angio pictures again, I'll just play them for you.
My only comment at this juncture,
yes, sir,
that whenever you are doing a case of Moya angiogram for fellows, everything,
yes, sir,
you should always do selective runs for internal carotid artery and external carotid artery.
Okay, sir. Okay.
Because what happens is that see, the diagnosis of Moya on MR angiogram, CT angiogram as well.
Yes.
What we want to know is whether there is an occlusion or whether there is a stenosis. That is number one. How much is the antegrade flow from the internal carotid artery situation?
Yes,
and then how much is, a lot of times from external carotid artery, you get natural collaterals after some time.
Yes,
so just like in this case, you have ACA territory.
yes,
so if you show me the lateral of the CCA, then both the collaterals from the external carotid artery and collaterals from the internal carotid artery, they merge together, and they don't give you a very good picture. So that is why generally you should always select these arteries and then do an injection for you, so as to that is number one. And that's basically it. Yes.
Okay. So this was the left CCA shoot. I'll just play this is the right common carotid injection. You can see the tapered ICU and the puff of the tapered ICA and the puff of smoke at the distal terminus. And this is the lateral view of the same shoot.
Yes.
Yeah. So this is the right vertebral shoot.
Right. So in this, if you see, so Moya is mainly compensated by the posterior side arteries and the puff of smoke, which forms the distal MCA later.
Yes.
Right. So these are the two main compensatory factors, apart from the natural collaterals which can develop later in the disease with the ECA territory.
Yes.
If you see on the left side, the vertebral artery gives a fairly good collaterals, at least in the posterior part of the MCA territory.
Yes.
On the right side,
yes,
there is a lack of the territory here.
Yes.
There is a lack of revascularization from the posterior cerebral.
Yes.
You also have involvement of the posterior cerebral artery vessels in this thing, and people have shown that worse the posterior cerebral artery territory contribution in collateral is, worse is the outcome in this. So this is a contributory factor, prognostic factor for the both the natural history of disease and also in the surgical management.
Okay, sir. So staging we all know I don't want to go into the single stage. So maybe this case we can put it as a stage 4 because there was some small minimization of the Moya, and the Moya change is reducing with occlusive changes in ICA and some tenuous ACA and MCA. Can we grade it as grade 4, sir? This particular.
Yeah, you can grade it grade. I would also want you to see what the grading. There is another grading which has come from the European group. So if you on Google, you can see that. That is a more simpler staging.
Okay.
What I would also want you to guys to know is that in a large number of cases, generally there is no major significance of this staging.
Okay.
Especially in, except for if there is some person who has very minor disease in stage 1.
Yes.
Most of the patients come to us in stage 3, 4, sometimes very 5 and everything. 6, generally you don't need to do anything, because the collaterals are really well developed.
Yes.
Those patients are not very.
Yes. So this is the grading, and maybe this particular case we can grade it as stage 4.
Yeah.
And third thing is you need to do the collateral grading. The first 3 pictures, the 1, 2, and 3, which you can see is, as I was telling earlier, either the collaterals should come from the anterior circulation, or it should come from the posterior or from the extracranial. So the first one, either it should come from the ACA to the MCA through the leptomeningeal vessels, or it should either come from the MCA to the ACA through the leptomeningeals, and either it should come from the anterior choroidal. This you can grade it as grade 1. And either second thing, either it should come from the PCOM or the PCA, or it can come from the posterior choroidal artery. So this is grade collateral grading. And below the 4, what you can see is either from the extracranial, the collateral should from the ophthalmic, or second, they should come from the middle meningeal. As we saw from the previous shoots, the middle meningeal was a big caliber middle meningeal which was supplying the collaterals, forming collaterals, and it would be from the superficial temporal artery. So this is the grading depending upon the compensation. So the grade 1 is from the anterior circulation, grade 2 from the posterior, and grade 3 is from the extracranial compensation. So this is the highlights of the picture. So first thing is you have one given grading of the disease of the Moya. Second thing, now we have graded the collaterals. Now third thing is, now you need to show whether how is the hemodynamic or how is the blood reserve. So there are multiple tests that are being done, either PET, SPECT, or arterial spin labeling, and in some cases TCD. For assessing cerebral hemodynamic changes, PET and SPECT have been useful for quantifying cerebrovascular reserve alterations, but there is one disadvantage where it comes to radiation concerns and some poor spatial resolution. And the hemodynamic status, the cerebral hemodynamic status was assessed by a dynamic susceptibility contrast MRI examination. The concept of this is a bolus of gadolinium-based contrast passes through a capillary bed, and the most commonly calculated parameters are CBV, CBF, and MTT. And it's particularly more challenging in children because it requires a gadolinium contrast with high flow bolus injections, and despite the disadvantage of providing several quantified perfusion parameters. And also, as I was telling earlier, there is one arterial spin labeling MRI. So these are the tests which are being done. So personally, I am not familiar with all this arterial spin labelings. Can just what is being done, sir, commonly?
Usually we do SPECT because it's very easily available.
Okay,
sir. And you can give some challenge as well in terms of Diamox or something else. Okay. Hyperventilation, Diamox, whatever you want to give.
Okay.
Usually we do SPECT. As a matter of fact, a lot of us will do MR perfusion as well. Okay. CT perfusion, I have not done anything, but people have done all kinds of things.
Okay.
Xenon CT, of course, is very difficult to get. PET also is very difficult to get. So it's you can send them for SPECT. They will many of them will have SPECT with challenge, and you can just have an oral Diamox. We used to say that IV Diamox is not available and all these things. But you can just use an oral Diamox that works, or some hyperventilation works. And you can do a baseline SPECT and then with a challenge SPECT, and you can see the cerebrovascular reserve in these patients. However, what we can also see is that, the angiogram itself will show you how hypoperfused the
Yes, sir. Yes.
thing is,
Yes.
So angiogram is also a perfusion imaging, basically.
Yes, yes. That's what I was going to ask you, whether is this mandatory, these tests are mandatory for as a pre-surgical evaluation, sir?
So no, they're not mandatory. It helps and it will have a prognostic value.
Okay.
Suppose you have done a revascularization and you show a betterment of SPECT, then you know that things are better.
Okay.
But what we usually do is that, suppose so many of these patients, when many of these patients are diseases are bilateral, but the symptomatic hemisphere is one. You understand what I'm saying?
Yes, sir.
So whether to revascularize the other hemisphere or not, that we rely a lot of it on the spectrum.
Okay.
Also, if there is a early stage disease, suppose the stage is 2 or something, and patient is having occasional TIAs, not much, not very severe disease. In those patients, we do want to do these kind of tests. And if the test is normal, then we can tell them to wait and not go for revascularization at this juncture and do it later.
Okay.
So these are the things, but many centers which are doing it, it is also of research value,
Yes.
So many centers do at least one perfusion imaging, at least for something, apart from all these other tests.
Okay. Okay. So this is an algorithm you can follow. Will make your things easier. So if at all you have a patient who has findings on vascular imaging suggestive of Moya vasculopathy, which includes both of the following, they should have a stenosis or occlusion of terminal ICA and or MCA, and also a bilateral collateral vascular network. And if at all the patient has any associated, you have to rule out few things to confirm it, like atherosclerotic intracranial stenosis or sickle cell or any APLA or any cerebral or systemic vasculitis. Once you have ruled them out, if at all the above things are there, then you can grade them or brand them as a Moya syndrome, and then initiate or optimize treatment for the above underlying condition. And if at all this patient still has symptoms attributable to Moya, like some TIAs or brain hemorrhage or dystonias or dyskineas, then you can refer them for revascularization surgery. And if at all you have ruled out all the above conditions and you are very sure about it, then you can brand immediately them as Moya disease, and then you can either refer them to revascularization surgery, or if not symptomatic, then you can initiate them on aspirin, unless if there is a hemorrhagic contraindication, and then perform a surveillance follow-up imaging at either 6 to 12 months to assess progressive intracranial stenosis. Either the options can be MRA, CTA, and DSA. And if at all the severe or progressive stenosis, then assess hemodynamic status as PET, perfusion, MRI. And if at all the results show you impaired cerebral perfusion, immediately you can refer them for a revascularization surgery. If at all not, again, you can do a serial neurological examinations, or you can repeat vascular or hemodynamic studies at 6 to 12 month intervals. So this algorithm will guide you in treating Moya patients.
Yeah.
So long-term aspirin for children, you can give them a dose of 2 to 5 milligrams per kg body weight daily, and in adults up to 50 to 100 milligrams with asymptomatic or symptomatic ischemic type Moya. Cilostazol is an alternative to aspirin, and long-term anticoagulation is generally contraindicated for children. And also pregnant ladies, patients with Moya should be instructed to maintain adequate hydration. And low dose aspirin is typically used for these patients for secondary or primary stroke prevention. And surgical revascularization, what is the pre-operative evaluation that we do? One thing is, of course, you should do a detailed clinical and cardiac evaluation. And in angiographic evaluation, as sir was suggesting, we need to do a bilateral internal and external carotid and also vertebral artery shoots to evaluate the sites of stenosis or occlusion and to see the status of collateral circulation and also to identify the donor vessels. And patients with recent neurological symptoms should be evaluated with brain MRI to identify if there are any ischemic hemorrhagic brain lesions to see overall stroke burden. And also time of surgery, generally you need to wait till symptoms improve, but in few cases like SAH or ICH due to, SAH due to aneurysms, you can treat it like any other aneurysm. And also sometimes it should be case based. There is no perfect protocol for this. You can do it on case basis. And surgical techniques can be divided. I'm not going too much into depth of the type of surgeries. Just as a broad consensus, there are two types. One is direct techniques and indirect techniques. Direct revascularization refers to procedures where the superficial temporal or middle meningeal, occipital, or any other donor branch from ECA is directly connected to a cortical artery within the ischemic hemisphere. It is used in many centers, most commonly in adult patients. Technically difficult to perform in children because of the small size of donor or recipient vessels. And in the indirect techniques, indirect revascularization refers to the several procedures where tissue perfused by a branch of the ECA is applied to the surface of the ischemic hemisphere, and the tissue may include dura, muscle, branch of an artery, or omentum, and is frequently useful, which you use for children with Moya. And in addition, it may be selected when suitable recipient artery is not available for anastomosis, and it requires less operation time and may have lower procedural related complications than direct revascularization. And broadly, the complications are few cases might have a perioperative stroke, sometimes a delayed transient neurological deficits, hypoperfusion syndrome, and infection and surgical site bleeding. So just here, I just want sir to come in. Sir, as a neurologist, I'm not very well versed with these surgeries and how do you proceed with these kind of cases, and how do you proceed with what type of surgery, whether direct or indirect?
Yeah. So the algorithm that you have shown is fairly fine. Yes. I think when you have a patient with suspected stroke with suspected Moya syndrome, you of course need to do all these other vasculitis tests and all.
Yes.
It rarely comes back positive, but yes. Then Moya is basically a disease which is diagnosed, one on angiogram, okay, and other on exclusion. Okay. So there is no real blood test for it and other things, though, even though there are genetic markers there. Yes. But so if the patient is having symptoms like stroke and everything, and there is angiographic appearance of Moya disease, especially if it is bilateral, even though 20% of them are unilateral, but you do that. And then we do an angiogram, and then we generally treat the symptomatic hemisphere. And then, as I said, based on the findings on the many people are symptomatic on both hemispheres, then of course you have to do surgery on both hemispheres. If the other hemisphere is well compensated, then we can just follow it up, or we can do it after some time.
For example, sir, if at all you have to take this above case, the first case which I showed you, yes. This is a young chap, 39-year-old. He had maybe 7 years back, he had an episode of stroke.
Yeah.
And it most probably was, as the image suggested, it was a medullary infarct. And now he has presented with seizure. You could see there is a particular area on the right hemisphere which is not being perfused. It is hypoperfused and the collaterals are not reaching there.
Yeah. So this guy is probably a good candidate for right side bypass.
Okay.
I would do a SPECT scan in this because I think his left hemisphere is fairly well compensated. So, but there is right hemisphere needs surgery. And then based on the SPECT, we will also see after this thing. Regarding the type of surgery, No, first we'll see when the surgery should be done.
Okay.
So generally, this has been my experience and other people's experience, that a patient who has had very frequent TIAs in the near past has a higher chance of having complication rates,
Okay.
because the complication is not because of surgery. Surgery is fairly simple; it's not very difficult.
Okay.
What happens is during anesthesia, during waking up, when the patient cries after surgery, pain, all these other things can precipitate a stroke. Anything which causes hyperventilation, anything which causes hypercarbia, all these things will precipitate a stroke. And that many a times, in almost 3-4% of times, that can happen on the opposite side hemisphere. Suppose you have operated on the right side, patient can have a left side stroke. So all these are very flow related. It's not that you have done a bypass and bypass is occluded and that's why he is having stroke. Most of the strokes are flow related, perioperative, anesthetic, or that perioperative management kind of thing. So if a patient has very frequent strokes, then obviously the patient's hemodynamic supply is very, very compromised. So what we do in many of these cases is give some wait it for some time, give medications. There is a medication called Midodrin, which is an alpha agonist, and that increases the blood flow. And once the patient is not having TIAs for the last 2 weeks or something like that, then we go ahead and vascularize. But sometimes we have to do it in emergency, not emergency as in patient keeps on having TIAs, and a stroke is not a problem. Stroke is an established stroke. You can do it after 2 weeks, 3 weeks, there's no problem. Problem happens when patients keep on having very frequent TIAs. Then the other thing is that there are very precipitating factors for this TIAs. So again, anything that can cause hyperventilation, hypercarbia, all these things will have these precipitating factors. Especially if I get many patients from Bengal and they say that whenever they eat very spicy food, the kid has TIAs. So those things are precipitating factors. It is wise to avoid all those things. To do, I always do combined revascularization unless I can't do it. So I will tell you when I can't do it, but most of the times we do a direct revascularization and then we add an indirect revascularization on this thing. Okay. So almost always, almost like 90% of times, I always do combined revascularization. There is fair bit of evidence now that in adults, definitely, but also in children, the results of combined revascularization are better than doing indirect revascularization. And the side effects or complication rates are no different. So except for hyperperfusion, which is definitely more in direct revascularization, but which is always reversible.
And do we continue antiplatelets after the surgery?
Yeah, I'll tell you. Yeah. So we never stop any antiplatelet during after surgery. So a lot of people stop antiplatelets for 5 days or 6 days before surgery. And it has been shown fairly well that people who are being operated on platelets have a better outcome than people who are not being whose antiplatelet has been stopped. Okay. So we always don't stop antiplatelets. Even clopidogrel is not stopped at any point of time, and I have never had any complication of those things because it's a superficial surgery. It's not a depth surgery. What the MCA that you is superficial region on the surface. You're not going to depth of it. So it is those things. After surgery, we do keep low dose aspirin for, as you said, this thing. Many a times we have to give low dose midodrine for some time to increase the blood flow in the graft and other things. You have to understand that even if we do combined revascularization, these half of the revascularization will be by the direct and the rest of the half will be with the indirect. So the indirect will take 3 to 6 months to mature. And in that period, people may have some TIAs here and there. That's fine. So yes, that is the one. And apart from that, we also give some anti-epileptics for some time, but that is just very often.
And in the follow-up, do you DSA or you rely on just an MR angiography, or when do you do it, sir? If at all you're doing post-surgery to see how the collaterals have formed, what is the time you will do a DSA, or you just will do some other imaging?
Yeah. So a lot of times, generally what is recommended is that you should do one DSA after bilateral surgery, 6 months after bilateral surgery, to assess the revascularization. Now, that is what we recommend, but many patients are very averse to doing any other procedure, DSA and everything. In those cases, you can substitute it with MR angiogram and MR perfusion, which is the most acceptable thing without any radiation. So we do an MR perfusion with MR angiogram, and we can basically see a lot of revascularization. Of course, you cannot have those pretty pictures that you can show with DSA. But as I said, a lot of people are, especially children, are very reluctant to do an angiogram again, especially because it is again to be done under general anesthesia. And every general anesthesia is a problem for these kind of patients. So we have to individualize, but generally the recommendation is that after 6 months of second surgery, you need to. Now, a lot of people do a CT angiogram or an MRI angiogram just to show the patency of the graft. I don't do it. You can check on ICG and just to see it, but yeah, you can do it. That's fine. That's not a problem.
Is there any urgency in treatment compared to ischemic and hemorrhagic events in the same particular patients, if at all, if they are coming with multiple TAAs or some small focal infarct, or compared to that, if at all they are coming with a ICH or a aneurysm, is there any difference in the urgency of the treatment, or is it the same, sir?
Yeah, so the only urgency here is when patient has an aneurysm, which you can show in the angiogram. That is very rare, but if you can show an aneurysm, you go ahead and if a patient has a stroke, then of course we wait for say 4 to 6 weeks before we intervene again, because the chances of having recurrent stroke is not very high in these patients. So in those patients, of course, in ICH, we wait for a little longer. There is good evidence that even for the ICH, the chances of repeat ICH is low in patients who have a revascularization than patients who do not have revascularization. But that evidence comes from Japan, which is called JAM trial. So we do revascularize, but after 6 to 12 weeks of the revascularization. The only time when we are forced to do semi-emergency is that even with maximization of medical treatment, and medical treatment would be aspirin, good hydration, midodrain, all these other things, the patient keeps on having TIAs. And in those patients, we are forced to do TIAs, surgeries in semi-emergency. But as I said, those are the patients who are at the maximum risk of having a perioperative complication. So you need to be very, very careful in those patients. Yeah.
So I just have another case, and maybe we can take some questions after that.
Yeah.
So this is a 40-year-old male patient. He came with some mild speech disturbances. He was telling he was not has had some word finding difficulties. Patient did not have any focal neurological deficit. So this is the image that he came with. As you can see, the MR angiogram, the right distal ICA terminus, you cannot find the distal flow, and you can see an A1 forming. So this was the MR angiogram he came with. So we took this patient for DSA. This is the left CCA shoot, where you can see a good ACOM and the ACA territory and some part of MCA filling from the left ACA through.
How old is he?
Sorry. So this is 40, sir. He's 40.
40. Yeah. Okay. Fine.
Yeah. He's 40. So this is the left common carotid shoot. And this is the right common carotid shoot that we have taken. So you can see the puff of smoke appearance at the distal ICA. And also you can see some filling of the MCA past the ICA. And also you can see a good ACA. So this is again the, just to see the collaterals. So this is a vertebral shoot, not much of collaterals coming from the posterior to the anterior circulation or the right MCA territory. So I found some few articles about the progression of unilateral Moya. The progression in few, this thing have told that the arteriopathy in this series, the average time of progression from unilateral to bilateral was about 2.2 years. And they had suggested pial synangiosis, which was safe. And in both patients with both bilateral and unilateral Moya. And this is one article where they have also suggested that the progression to bilateral lesions is known to occur in pediatric patients, and surgical treatment on the symptomatic side followed by closed observation of bilateral involvement is recommended. And this is another article where they have found that the contralateral progression in the adult form occurs more commonly than previously reported, and the presence of minor changes in the contralateral ACA, intracranial ICA and MCA was an important predictor of increased risk of progression. And patients with completely normal angiogram on the contralateral side have a lower risk of progression. So generally, if we have these kind of cases, how do we proceed, sir? I mean, the same as they are suggesting, treat these kind of.
Yeah. So see, there are 20% of cases which are unilateral,
Yes.
which do not have VA. Even though I would be very wary of calling them as Moya disease, but really, I mean, you don't know what they are. But the fact of the matter is that even if they are syndromes, unless you find a vasculitis marker or anything, you treat them with revascularization itself.
This guy's MRI was normal. So sorry to interrupt. This guy's MRI was absolutely normal. There were no chronic infarcts, or there was no acute infarct that we found in the MRI.
So why was he presented? What was he presented as?
He came with some mild word finding difficulties. So very mild speech disturbances. Okay. So they had done an MRI outside which had this finding. So they had come for consultation.
So in these kind of patients, the perfusion studies are most important. So that is the most important thing. And if it shows a very minor defect or no defect or no cerebrovascular reserve problem, then we just follow it up. But if it shows major thing, then we do offer them some surgery. The chances of his left-sided being having a problem is very low.
Yes.
That is very low here. Even his right side is fairly well compensated both from antegrade and the ACA territory leptomeningeal collaterals. So it is like the usual carotid occlusions that you see, MCA or carotid occlusions that you see, and the decision making is like that rather than a straightforward Moya patient. So in this patient, I would definitely do a perfusion study with diamox. And if there is a major defect in some place, then we offer them surgery. As I keep telling, the surgery itself is really not very complicated, and the perioperative complications are not very high in these patients, especially in patients who have occlusions, especially in the patients who have who are not symptomatic too much symptomatic or something like that. But yeah, of course, surgery is a major event and you should be able to justify this thing. So you would do a perfusion study in this and then take a call whether you want to do surgery. Yes.
So these are the two cases that I had. Now the forum is open for doubts. Anybody who has any doubt can just turn on their mic and ask their doubts. Anybody?
I think we have, there is a lot of awareness now for this disease as regards like last 10, 15 years. And it has been increasingly recognized.
Okay.
I do think that a lot of them will require surgery, especially the symptomatic one. And surgery has fairly good results here. So yes, how to proceed if there is both ischemic and hemorrhagic event. It doesn't happen usually. That's a case report. We actually published one case where in a child where you have a patient had ischemic on one side and hemorrhagic on the other side. But in general, they present with one kind of symptoms. Kids will present with almost always with ischemic symptoms. Even more adults will present as with ischemic symptoms, but the chances of having hemorrhagic symptom is higher. So yes, usually does, I mean, almost always it does. It picks up on one side and has both. But if it does, then you treat it on their own merit as to how which side is symptomatic. You and hemorrhage ischemic side because Moya has better in ischemic event first and then the hemorrhagic event. So yes, I think you should evaluate these things. Like if it's a pediatric patient, then you should do everything in your stroke in young protocol, pediatric stroke, whatever investigations you give. And if you find a cause, well and good. If you don't find a cause, then of course MR angiogram, MR, and if you're doing an MR, you can do a perfusion regarding in during that time itself, and then an angiogram. A lot of times, what we do is that we know all the diagnosis from the angiogram, and we do an in I do things. So I do an angiogram in the same anesthesia as the first surgery because and of course this, but you can do it other way as well. It doesn't really matter. In patients who are very mildly symptomatic, and it's been just up on the surface.
Do a selective, because most probably I'll be doing the DSA and then probably referring the patient to a neurosurgeon for surgery or an interventionalist. So maybe do selective angios just to see and assess the occlusion and stenosis and to see better visualize or assess the donor arteries, so that it makes, because we cannot do it again and again, so it makes a huge difference for planning the surgery.
Yeah, more than the donor artery, actually donor artery you can see on the surgery itself, you know, it doesn't really matter. More than the donor artery, what you need to see is the level of revascularization which has already happened from surgery. So suppose there are patients in whom there is a fairly good revascularization which has happened through middle meningeal artery. In those patients, you have to be very careful in your craniotomy because you can easily injure these middle meningeal arteries, and that will precipitate a stroke. So the extent of revascularization, there are people who also direct their revascularization towards the lobe where the hypoperfusion is. So as you showed in the first case, there was in the posterior frontal region, there is revascular hypoperfusion which was there, which can be seen with SPECT also. So in those patients, we take the frontal branch of the MCA and revascularize it there, you know, rather than the temporal branch. So you can direct your revascularization on that side and direct your surgery on those sides. So that is why we do selective things rather than just seeing the donor artery. But to see, more importantly, to see what is the level of revascularization which has already happened. And in a lot of patients, you will find extremely good revascularization happening and they don't need surgery at all.
And you brand this unilateral ones as Moya Moya, or you wait till it becomes, because per se the Moya Moya is supposed to be bilateral. Do you brand them as Moya Moya disease entity, or we just have to give the name like a unilateral arteriopathy, vasculopathy, or then in subsequent scans, then only we can brand them as Moya?
No, we brand them as Moya disease. That's a well-known entity these days. I think that is a problem. What you can confuse it with is the focal cerebropathy that you can get in young adults. That is a specific condition where you get a very tight and circulation, mostly in ICA bifurcation or early M1. And that's a fairly good entity. And that a lot of that can be just treated with some steroids, and that usually gets better. So those patients who are 20 to 25, 30, those you have to be very careful with before branding them as unilateral myoma. But in these kind of patients, really, it doesn't matter. But you need to be aware of that condition called focal cerebral arteriopathy of the young. And those are treated with just medications and aspirin and not with surgery. So those things you need to be very careful to brand them as unilateral myoma.
Sure, sir. Sure, sir. If anybody else has any doubts, can ask us, we can end this session. So thank you very much for joining us. Thanks for your valuable insights.
Anytime. What is there? There is no value in my time.
Thank you very much, sir. Thank you.
Anytime.
Good night, sir. Thank you.
All right. Good night. Good night, guys. See you.